Well, hello, my name is Brian Badgwell. I'm a surgeon from MD Anderson. It's a pleasure to get to speak to you as part of the Stomach Cancer Awareness Network. I'll be talking today about HIPEC for gastric cancer. So that's something I've dedicated my career to, so it's always a pleasure to talk to you about that. I have no disclosures. I think this can be a complicated topic to talk about, and so I hope I'm able to shed some light on it today. But I thought I'd start with first talking about how gastric cancer spreads, then what is HIPEC, how HIPEC has been used for gastric cancer. I think it's a difficult decision whether to go with chemotherapy via the veins or second-line chemotherapy or some of these aggressive surgical techniques where we apply chemotherapy within the abdomen. And then another difficult discussion and decision is, should the stomach be removed in stage 4 gastric cancer? And so it's certainly my pleasure to be here and try and tackle some of these difficult decisions with you today. So I hope this is helpful for you. I thought I'd start with just talking about what is the peritoneum. And I think the best way I had a patient explain this to me was describing it as the stomach being a pillow that's within a pillowcase, where the pillowcase is the peritoneum. And you can get in between those two structures and distend with air, in this case CO2, and then look around and see if gastric cancer has spread. And so that's what we're seeing here, where you see the stomach in the bottom with some white changes, and then over here on the abdomen you can see some white dots, which represent spread of the cancer, where it's spread from the stomach to that inner lining. Now, there are two ways that gastric cancer spreads within the abdomen and represents stage 4 disease. The first is called carcinomatosis, and that's where you see the thickened white stomach here, and it spread to the lining of the abdomen with white changes. And those white changes are only about 1 millimeter or maybe 2 in thickness, and so this is why it's very difficult for a CAT scan to pick up this type of spread of disease. In addition, there's another way it can spread, and this is a microscopic mode of spread, and this is called cytology positive. And here you can see a stomach also with some white changes, but you don't see any white dots on the lining of the abdomen. And we only pick up this disease when we put some saline within the abdomen, take the saline out, spin it down, and look for cancer cells. And if we find cancer cells, that also, even though it's microscopic, is stage 4 disease. And so HIPEC is hyperthermic intraperitoneal chemotherapy. So hyperthermic, it just means applying heat, which theoretically has a direct anti-tumor effect, putting the chemotherapy within the abdomen, and the tumor is bad when you have to put the chemotherapy directly on the tumor, and then using agents that work better with heat. So hopefully you get a synergistic effect where we use drugs like mitomycin and cisplatin and paclitaxel that can work better with heat. Now, it's the standard of care for appendiceal mucinous tumors, and so I'm sorry for these gross pictures here, but on the left you can see an appendix that's been cut out with a small tumor in it, and if this tumor is not removed, then it can rupture, similar to appendicitis, and then create this mess here where you have this copious amounts of gelatinous tumor that's filling these buckets, and that has to be removed with an aggressive surgical technique. And then we apply heated chemotherapy, and this is a perfusion pump system here, and just has a roller pump where the chemotherapy is pushed in and out of the abdomen, and there's a heater element here that heats it. And this is the standard of care for appendix tumors and mesothelioma. It's a little controversial for colorectal cancer, and it's certainly controversial for gastric cancer. Now, this is the only completed randomized controlled trial in gastric cancer. And so that randomized controlled trial just means that they've taken patients in 2 separate arms and treated them differently. And it's randomized, so it's just chance which arm the patients go into. And so and this is a study out of China. Now, almost half of the gastric cancer in the world comes from China. And so this is very small for them. It was just over 30 patients in each arm. But what they did is they compared patients undergoing a debulking surgery, meaning just cutting out all the tumor and the stomach, versus that same surgery with adding the HIPEC. So does adding the heated chemotherapy add anything? And they used mitomycin and cisplatin. All of these patients had visible white dots or carcinomatosis. And this is a survival curve here. And so what we want to see is the higher that line is, the better. That means better survival. And the time in months is on the bottom axis. And so we can see that adding the HIPEC, as shown in the blue, lifted that survival curve up a little bit compared to the yellow, which is the debulking surgery alone. So, this isn't a perfect study, but it's a bit of a signal that HIPEC may add something to the treatment of gastric cancer. Now, this is a bigger study, and this comes out of France. So this is called the CYTOCHIP study, and this was published in the Journal of Clinical Oncology, kind of our premier cancer journal. And so what they did here was, again, very similar to what that Chinese study did. Both arms got the gastrectomy and the debulking surgery, but in the blue, they added HIPEC. And you can see, again, another lift in that survival curve compared to the red without the HIPEC. Now, the peritoneum is still a problem, though, and that's shown in this pie graph up here in the top right, where the patients in the green and red still had a recurrence within the peritoneum, or that lining, that inner abdominal lining, whereas it's the patients in the blue, when they recurred, it was outside of the peritoneum. So I think that just shows that, this isn't a perfect surgery or a treatment, and we have to be selective in who we perform this aggressive surgery in. So when we wanted to study this at MD Anderson, because we were starting to see some of these results come out that suggested a benefit, but we also wanted to be very safe. So some of those studies had very high mortality rates or death rates with surgery, and a lot of complications. And so if this HIPEC was going to work, we wanted to prove that it worked before we removed the stomach. And we were also very concerned about removing the stomach and applying the heated chemotherapy at the same time. So this is how we designed our study, as shown in the top right. It was a single-arm phase 2 study, meaning it was not randomized. We did not have a control arm to compare to. And of course, all patients had to get systemic chemotherapy. And I think it's important to note that that's standard of care, and we wanted all patients to complete that standard of care. But then we performed a laparoscopic HIPEC procedure. So this was a minimally invasive procedure done through 3 small incisions. We used those drugs, mitomycin and cisplatin, and this could be repeated. So if the HIPEC was going to work, we wanted to make it work, and it had to get rid of all the cancer outside of the stomach, to the best of our ability to find it. And so if we had negative cytology, meaning those negative washings, no carcinomatosis, meaning no visible white dots, and then no imaging metastases, meaning a good high-quality CAT scan with no imaging evidence of spread, then we would offer a gastrectomy alone, so just removing the stomach. Again, we did not add the HIPEC at that time. And with that, we saw that survival was promising. So these survival curves look similar to what I showed in some of those other studies, and just a signal there that there was a chance for getting long-term survival, or getting survival beyond 5 years, maybe even a cure, although these results are still early and the numbers are very small. So with those promising results, we went to a more aggressive study. And so this is a very similar study, but again, it's the same population, patients with that positive washings or peritoneal disease. And then of course, everybody got systemic chemotherapy. Then we would perform at least one minimally invasive HIPEC. And the benefit to doing that is you get a diagnostic laparoscopy. You're putting the camera within the abdomen. CAT scans are notoriously poor at finding that disease outside of the stomach, just because it can be so thin. And so I think that helps. But if it looked like patients were able to undergo a surgery where we could cut everything out at that time, and they tolerated that minimally invasive HIPEC well, then we would offer the big surgery I kind of badmouthed just a minute ago, where we perform a debulking, a gastrectomy, and the heated chemo at the same time. And what we saw was the survival rates were a little bit improved. So again, we see the survival curve that's similar to what a lot of the other studies showed. And we're starting to get close to 5 years out with patients here. And why that's important is if the cancer hasn't come back within 5 years, we think that perhaps it won't come back. And so again, we are very just excited about having some promising results. And of course, there's been a lot of basic science studies trying to find out which patients benefit from this approach, trying to find new markers of ways to treat stage 4 gastric cancer. So I think it can be difficult with all these different options, even within the HIPEC realm, of what to do. And so this is our peritoneal program and our algorithm, how we take patients down this. And so I thought I'd just go through this for just a second and hopefully provide some clarity. So everybody, of course, is treated with first-line chemotherapy, and it's important to have a multidisciplinary conference and get everybody involved. There are some targeted agents and immunotherapy options here, and so you just want to make sure you don't miss out on those and have all the right markers looking for treatment options. But if the patient has a good response to first-line chemotherapy, I think you come down to basically 2 options then. If you see progressive disease, it's either going to be second-line chemotherapy, or it's going to be going down this laparoscopic HIPEC approach. At the time of that laparoscopic HIPEC approach, if you go down that arm, then you have a diagnostic laparoscopy, you have biopsies, washings, you have new information, you go back to the multidisciplinary conference, and then, again, there's some more decisions to make. You can go down the gastrectomy, cytoreductive surgery, and HIPEC approach. That is a tough decision. It is a lifestyle changer. It's a big surgery to get over, and so you have to have a lot of discussions before going down that route. or you can go the repeated laparoscopic HIPEC approach. Of course, next-line chemotherapy or certainly trial options are always important at this time. On the side here, there is some data out there that laparoscopic HIPEC can be a good palliative treatment for malignant ascites. Again, not to so much improve survival, but just to get rid of that burden of having frequent paracentesis or drainage procedures for fluid that builds up within the abdomen. But anyway, that's kind of a different talk for a different day, but I just wanted to acknowledge that as an option. Now, we have tried to do some studies, again, to find out who benefits the most from this peritoneal approach. And so I was going to show a few of those on the next two slides. And so in the first one, you know, we realized that we don't have that comparison arm. We don't, you know, these are not randomized trials, and there's no way to get around that. But we did want to go back and try and find a comparison arm. And so this was a very honest study where we went back and we found patients that did not undergo the laparoscopic HIPEC approach due to insurance not covering the procedure, or they didn't want to stay locally and undergo the treatment, or just chose to undergo systemic chemotherapy options. And so that's what we see here in the blue. That's standard of care, which was systemic chemotherapy alone, compared to the patients in yellow. I'm sorry, that doesn't show up very well, that underwent the laparoscopic HIPEC approach. And so again, with this survival curve, you want to see the curve be higher. You see a little bit of a lift with the laparoscopic HIPEC approach. But what you also see here is this little p value up in the top right of this graph. And so that's 0.08, and it has to be 0.05 for it to reach statistical significance. So this was a negative study from that standpoint, meaning we did not clearly show an improvement in survival. Now, you see this a lot in these retrospective studies where you go back and look at it. And if we compare the patients that underwent standard of care systemic chemo in the blue, here in the top right figure, compared to the patients in green that underwent the laparoscopic HIPEC plus the gastrectomy, well, then we start to see that significant survival difference. Again, it's not, you know, these aren't great studies when you go back and do this retrospectively, but a little bit of a signal that we think this may work. Now, the next study we did is we wanted to look at factors associated with survival in all our patients. And one thing we picked up on with this study is that ascites is a really bad sign. It's that ascites at initial diagnosis, even if it goes away with systemic chemo, it tends to be pretty bad. And so what we've shown here is that patients in the yellow initially presented with ascites compared to patients in the blue that had no ascites, the survival was just much different. And so we routinely don't offer, you know, HIPEC and gastrectomy if there's ascites. We're always looking for patients that can tolerate that, but that's a tough situation to be in. The other thing we did is we looked at patients with their disease and calculated a peritoneal carcinomatosis index, or PCI. And that's just a way to go and break the abdomen up into quadrants and give a number to those little white dots and calculate how much disease. So you want as low a PCI as possible. The higher the PCI, that's bad. And so what we saw is that patients with a PCI of essentially 0, as shown in the blue, meaning the little white dots resolved with systemic chemotherapy, or they had positive washings only, well, those patients had the best survival. So that's where we're most enthusiastic about doing this. Now, if the PCI is less than 7, as shown in the yellow, there's still, you know, some survival here. But once you get to the green where the PCI is greater than 7, then that's just bad. You know, it's a bad and a tougher situation. So I think we have to be selective on who we're offering this treatment to. And so these studies have helped us sort that out a little bit and help us, you know, inform our patients when we see them in clinic. So taking a step back, I think it's sometimes helpful to think about how we treat tumors that are localized to the stomach. So this is the non-metastatic setting. Of course, we'll always give chemotherapy or sometimes chemoradiation before surgery. And these are the reasons why. You know, we want to shrink the tumor. We want to get negative margins, get all the way around that tumor. We get to assess the response in the tumor. We avoid unnecessary surgery. Perhaps we can prevent spread of the tumor when we manipulate it at surgery. And then patients tolerate that treatment better before a big surgery. You know, once you've had a subtotal or a total gastrectomy, about half the patients can't tolerate chemotherapy afterwards. So again, I'm not talking about in the metastatic setting here, but I think when we're talking about surgery in the metastatic setting, sometimes these principles can be applied to that. And so let me show what I mean. Is that so subtotal or total gastrectomy is still a very big surgery. And so I just wanted to show a few pictures here to acknowledge that. And even with a subtotal gastrectomy, as shown in the middle, you're left with a small gastric pouch. It's a lifestyle changer. And certainly with a total gastrectomy, as shown on the right, you know, patients have to eat small, more frequent meals for the rest of their life. certainly can drop 10 to 20 pounds until they get to a new normal. And so it's just takes a long time to get over that, and it's just a big surgery. And so with that in mind, I think some of these theoretical advantages can be applied in the metastatic setting. And so we're all looking for some way to beat down this tumor outside of the stomach before we perform a gastrectomy. For all those reasons that we do it in the localized setting when it hasn't spread. And so I just wanted to acknowledge that there's certainly many different approaches that are being talked about. There's the laparoscopic HIPEC approach, which I talked about today. There's intraperitoneal paclitaxel, where you can put a port within the abdomen and apply non-heated chemotherapy multiple times. There's a PIPAC approach, which is pressurized aerosol chemotherapy. There's a MIPS approach, which is giving intraperitoneal and systemic chemo, so chemo via the vein and chemo within the abdomen. And then again, when you get to gastrectomy, do you just do the gastrectomy alone? Do you continue the intraperitoneal chemo afterwards? Do you add a HIPEC here? So I just wanted to acknowledge that these are difficult decisions, but they're best made in a team fashion when you're dealing with investigators that have dealt with this quite a bit. I also just wanted to mention that we are looking at the intraperitoneal paclitaxel treatment. There's been a lot of enthusiasm for that in Asia. Gastric cancer is very common in that region of the world. And so what we're doing here is, again, all patients have to undergo systemic chemotherapy. Then we place a port within the abdomen, as shown here on the right side. And then we treat with intraperitoneal paclitaxel. You can see the catheter within the abdomen and those white dots showing carcinomatosis. And then we can repeat the paclitaxel treatment every week. And so we've been moving along on this. We're now on the highest dose, and we've had a few patients get to gastrectomy on this. So we're always looking again for something where we can beat it down and be selective in who we put through an aggressive surgery such as gastrectomy. So, with that, I just wanted to thank you for the chance to provide some updates and talk about HIPEC, and also invite everybody to the International Gastric Cancer Congress in 2022 in Houston. We like to draw a red line through cancer here in Houston, but we had to draw a red line through 2021 and move it to 2022 because of the pandemic. But we will have a patient symposium here, and it should be online as well for certainly our patients that don't want to travel, and have a lot of our patient advocates there. And so again, thank you very much for the chance to talk to you today.